All right, let's kick it off with joints. So there's cartilaginous joints and then these fibrous joints as well as synovial joints. Here we're looking specifically at a fibrous joint. In the suture here, we recall in development that there is more and more space in between, and this fibrous tissue is there so that there is room for the brain to grow. And then eventually in post-adolescent adulthood, it's completely ossified. So that doesn't happen throughout the lifespan. It's not prevalent there throughout the lifespan. It's just in early development. But this is what connects the skull, and we only find the suture in the skull, nowhere else in the body. So syndesmosis has a bit of movement. It's a bone-to-bone joint connected by a ligament only, and depending on the length of that ligament is the amount of movability available there. This is a nice one in the tib-fib area to demonstrate that. Again, fibrous connective tissue. The gomphosis is a peg and socket joint, and it's only found in the jaw with the secondary teeth, and it fits just like a nail into a bed, and that joint is called a gomphosis. So the next one, these cartilaginous joints are made out of cartilage as opposed to that fibrous connective tissue, and here are two examples of where they are. The epiphyseal plate, so again, that would ossify eventually post-adolescent. And here, which doesn't ever ossify, those remain through the lifespan, is that immovable joint between the costal ribs and then the sternum. So this joint is, generally no motion. A symphysis, on the other hand, has a little bit of motion. Here we see the fibrocartilage of the intervertebral disc, and we'll see that again here, and then alongside the pubic symphysis. So both of these are slightly movable joints. We'll look at synovial joints in a minute. Here, the ball and socket joint is a great one that we'll use to look at how synovial fluid joints work. Synovial joints work, but for now, let's just name things by how they're classified by their shape. Okay, so joints are also classified by this. Condyloid or ellipsoidal are found in the hand. This gliding joint is found in the carpal bone. A hinge joint, right, is that ulna on the humerus. The pivot joint is here with the radius and the ulna, so that's that turning supination pronation moment. And then a saddle joint right here at the thumb is the shape of the bones give it that name. All right, so this is a synovial joint, and here we'll see some of the typical characteristics that make up a synovial joint, including hyaline cartilage at the end of this long bone. We have a tendon sheath that has the same characteristics as a bursa. It's just in a long form. So let me go back and describe a bursa first. So a bursa is a fluid-filled sac, right? So it's just it's a sac that allows for some cushioning between a ligament here and that hyaline cartilage at the end of the long bone there, right? So it's cushioning, shock absorption, decreases friction, and allows for a range of motion for movement. So it's colored and depicted the same because it has the same characteristics here, but what it does is it follows along a tendon. So then it is it's classified as a tendinous sheath and not a bursa. So this bursa here is named subacromial, right? Because it's below the acromion, or the acromion process of the scapula. So each bursa is named there by its location throughout. Here we have a bit of the articular capsule. So this would be a dense connective tissue that is going to reinforce the shoulder capsule. So let's look at some of the bone features from the beginning. Here's our compact bone covered by the periosteum, right? The ligament does attach to the periosteum, which attaches adheres tightly to the bone. And then right here we have a fibrous capsule. So again, it's a bit more of this fibrous tissue that allows for more protection. It also strengthens the stability of the joint. Here we have a joint cavity or a space. And here we have the synovial membrane, which is going to, I want to say leak, transmit, it's going to excrete the synovial fluid that lubricates that joint. And then these two structures together are known as the articular capsule. Okay, so the most violent human motion ever measured. So here's a picture of Pedro Martinez, and the shoulder is going into external rotation, and there's a torquing moment here also at the elbow. So I'm using this because pitchers tend to suffer injuries of the shoulder and the elbow, and it has to do with the reinforced ligaments and then the extreme power, right? They're delivering so much force and power in an explosive motion from an externally rotated, extended, hyper extended and reach, and they throw that ball, 70 miles per hour, more than that, and it can lead to injuries. So here we just see the bones, right? But if we look at everything that's reinforcing the stability of the shoulder, we have all these ligaments and tissues that are helping to provide stability. So the nature of the shoulder, right, is that we want range of motion in myriad directions. So we're moving 180 degrees, flexion, extension, abduction, adduction, right? We have full range of motion here, and that allows us to function and work in different planes at the same time. So the shoulder stability does not come from the bone in the joint, right? So this is the glenoid cavity, and here's the humeral head, and this is a very shallow joint cavity. This is why you can easily dislocate this joint, because the only thing that's keeping it together, really, right? When you're talking about using extreme force, are these reinforcing ligaments. So and the capsule. So here we're just prone to injury in this. Pitchers from wear and tear, also mountain biking, that's my community, and people fly off their mountain bikes and they hit a tree, and then they tend to separate in the ligamentous area. The scapula separates down from the this gets stretched there, and it changes the stability of the whole glenohumeral joint just based on a shift in the scapula, right? Can you imagine? Because that would affect it. So yeah, so shoulder stability, form and function, if we think about it that way, the function of the arm is to reach, grab, extend, pick up things, manipulate things, right? So we need more range of motion, and that's why it has more flexibility, or it doesn't have such a deep joint socket. Here's a labrum, which is it's the tissue that's covering the bone of the joint, and that allows for rolling to happen with decreased friction. Again, that's the glenoid cavity, and here we're just simply looking at this from a different view to see the reinforcing capsule around here and the ligaments. So tears in the glenoid labrum are common. Damage to the articular capsule is common with wear and tear, and sports injuries as well. Again, physical therapy, you can test for exactly where the lesions are to help diagnose and treat those issues. Bursitis, just moving along to a different pathology. So that's when the fluid-filled sac becomes inflamed, which can become inflamed due to overuse. So it gets bigger. With all inflammation, right, we're talking about a swelling happening, and then that decreases the normal space within that area, and it leads to pain. So there's pressure put on tissue, muscle tissue, that leads to pain. So we have bursitis can happen in the subacromial space here, as illustrated. So I'm just putting the elbow in here now because I mentioned it with pitching, that torquing motion between the shoulder and the elbow, the pitching affects both those joints. The noteworthy things here are that, let's just go. Here we have here's our cartilage, right, allowing for that motion. Here's our bursa. Again, we have a capsule around, so there's the same type of reinforcement or cushioning happening at that joint area, including those bursa. I have 3 ligaments listed here: the annular, the ulnar, and the radial. So the ulnar and the radial are simply on the lateral sides of this joint, and the annular ligament is going to be located around. So here it is, around the radius. There's that ligament, right? So here's our radial and collateral. Radial collateral ligament, ulnar collateral ligament would be on the here's the annular, here's the radial, and then we have to flip it for the ulnar to look at that on that side. It's called the ulnar collateral. Again, underneath the olecranon is that bursa, and you can get bursitis or inflammation there. You can lean on your elbow long enough, right? You could get it. There's something called student's elbow as well, from excessive pressure put on the elbow for lots of time. What about the knee? The most complicated joint, right? We have the patella that's going to glide. We have a roll and a glide motion for the kinematics when the knee bends back and forth. We have the tendon of the quadriceps here. What goes into the patellar ligament that inserts here at the tibial tuberosity, right? We have our collateral ligaments here. This one's called the fibular collateral. This one's the tibial collateral. And then you have some retinaculum, which is, again, dense fibrous tissue. It's just a little bit flatter, longer, and thinner than when you think of a ligament. So here we see more of the reinforcing capsule, right? The articulating capsule. We also see a little bit on the because we're looking at the posterior side, we see more naming. So we have the arcuate popliteal ligament, right? And there's a lot of different ligaments that we can name. I'm just pointing them out. This is not something that you have to memorize until you go further in your studies, depending on your path. But just know that each ligament has a name. Here we have the gastroc is taken away in this image so that we can see in here. And same with this tendon of the hamstring muscle that had to be removed in order for us to view the capsule and in these posterior ligaments that are there. So strong reinforcement in the knee for sure. When we go deep, right, we reflect back the patellar ligament, and we can see the ACL, right, the anterior cruciate ligament. We have the posterior cruciate ligament. These two, we'll look at what happens with a blow. You tend to damage the ACL with a lateral blow. The posterior one can get damaged, but it's mostly in like an auto wreck where you get a dashboard knee injury could affect that. So the most common injuries we see between those two are actually in the ACL. Here's our meniscus, right? So this is a disc that is reinforcing the cushioning on top of the tibia below where the femoral condyles will move and articulate on that. So it's a bit more cushioning. We can see the shiny hyaline cartilage illustrated here. So here's our knee joint. Lateral blows to extend knee can result in tears in the tibial collateral ligament, the medial meniscus, and the anterior cruciate ligament. So let's look at this in here. So it's a lateral blow in stance This can happen in football. It happens in a lot of different sports because people are running, like say soccer, and you have your stance leg to stand on, and then you're going to kick. So you have an extended, strong, a stant leg, even though there's like a slight bend in that knee, it's enough. If someone comes in from the side and blows you laterally, that force will transmit through, right? It's not going to affect the lateral side for severe damage, but rather it's going to affect the medial side. So you get damage to the medial side here. The medial meniscus is what ends up being torn. The tibial collateral ligament, again, the tibial is medial, and then it's the ACL, so the anterior cruciate ligament that gets torn. This is called the unhappy triad. It happens frequently enough in sports injuries that it has its own nickname. So there's another way to talk about this. This is the 3 C's: the collateral, the cruciate, and then the cartilage. But for the most part, it's the unhappy triad that we see clinically. Just another picture of bursa. So this is in the knee, clearly, but there's something also called nursemaid's knee that people have a inflamed bursa, and that can happen from a repetitive kneeling, and sometimes it happens in adults who have children, and so for the first time in 30 years or 20 years, depending on their age, they're like playing around on the floor on their knees, and they end up aggravating their bursa. All right, this is just to look at the pelvis. We're going to look at this hip joint here, but just to see the full view of your ilium, ischium, and pubic bone, and then here's your femoral head. There's the sacrum. Okay, so now we're zooming in with the femoral head here, the neck, and this is going to be the rest of the femur. We see our acetabulum, and what I want you to recall is how shallow the glenoid cavity and head of the humerus was, that shallow articulation versus deeper articulation here in the hip joint. So the same things apply here as far as structure. There isn't a bursa right here in this area, right? But we still have our synovial membrane that's allowing the synovial fluid to lubricate the joint and keep it gliding and moving well. We still have some ligamental reinforcements, and we have something called a labrum also coating the inside of the acetabulum that's going to articulate with the head of the femur. But again, look at with the neck and then the deepness here, right? We can see this is deeply jointed together as opposed to a shallow joint. Here you can see it removed in this cadaver image, and you can see the capsule here, the reinforcing tissues that really hold it in tightly, right? So if we think about the difference between what our legs do and what our arms do for activities, the leg is about stability, foundation, walking, standing, holding, bearing up the weight of the upper body, right? So that's why this joint is a deep socket joint as opposed to a shallow socket joint. We lose range of motion in exchange for stability. Here we go. So ligaments again, ischiofemoral, right? It's named because it runs from the ischium to the femur. That's common with our naming of ligaments. That's the convention usually. And here we see the pubofemoral. So again, just a lot of ligaments reinforcing hip stability here. And again, that is what's going to make even the bone of the acetabulum is deeper that the head of the femur sits in, and then you have these ligaments around them, increasing the stability. This is again what I'm saying about the deepness of it. Okay. This is a picture of a bone cyst, so you can see this on the radiograph. So you can imagine that if there's a buildup of calcium, right, or the hard mineralization in a place that it doesn't usually exist, that this is going to decrease range of motion. It's not going to glide as smoothly, and it's also going to probably present painfully for the person as well. A little bit more here. This is just a hip fracture that's stabilized here with a screw. This would be an internal fixation. And then once that's healed, the hardware would be removed. But it keeps the bones, the two bones approximated. Otherwise, they might be too far apart. Let's pause here, guys.